Good morning, everybody, and welcome to the April webinar. As you know, Jenny and myself never like to miss an opportunity to share one of Charlie Mackesay's beautiful drawings. So hope that was a nice picture to reflect on first thing this morning. Next slide, please, Sean. So just a reminder in terms of housekeeping, as usual for the webinars, if you could mute your lines and turn off your videos until we have the questions and discussion. Please feel free to raise your hand to ask questions, give feedback, and also use the chat function. The webinar is being recorded, and so those people that can't join today can watch at a later stage. Thank you very much. Next slide. So today's webinar is focused on marginalised groups and in particular thinking about care leavers. As usual, we've got some great speakers lined up. So I'll give a brief national update in a minute, and then we're lucky enough to have Becky Burgess-Dawson from Health Education England is going to be talking to us about the National Mental Health Programme Trauma Informed Learning. Then Mark Riddle from the Department of Education is going to be talking about the National Advisor for Care Leavers. And then we've been doing the feature for the last couple of webinars in terms of Hello, my name is. And today we're joined by Fiona Butt, who will be talking about her role as family nurse partnership within Hampshire. And then we'll finish off the session this morning with Jenny giving some of the latest resources and an update on some of our training places. Okay, thank you very much. Next slide, please, Sian. So a brief national update from myself. Next slide, please. So first of all, some really good news. So as many of you will know, although there's been a real push to increase the number of mother and baby units within England and have provision across the whole of England, unfortunately Wales has not had the same provision, but we have a mother and baby unit opening in Swansea Bay. Now Jenny tasked me with trying to say the name of it in Welsh, and I am no Alex Jones or Hugh Edwards, so I'm not even going to attempt it, but the translation means Unit of Hope, which is rather lovely. So the new unit will be based at Toner Hospital near Neath in Swansea Bay, and until this point in time, obviously if women in Wales have needed to have specialist care in the mother and baby units, they've had to travel to England, and the nearest unit has been Bristol. So this is really fantastic news, and there's a bit more information about the new unit on the slide that you can read at a later date. Okay, next slide, please. Okay, so I just wanted to revisit the perinatal mental health access metric. So we shared this slide last time, and it's the question and answers, but I wanted to highlight that question 2 has now been amended in terms of its answer. So if we go on to the next slide, please. This is now the updated Q&A for question 2. So how should systems ensure that all face-to-face and video contacts are counted in the national figures? So to highlight again, it's really important that all contacts are recorded, so not just the initial contact, but all contacts onto the IT system. And then it's the responsibility in terms of the provider trusts for your informatics teams or your business intelligence teams to be flowing all of that recorded data to MHSDS. And then what will happen is obviously nationally NHS Digital will extract that relevant information from there. But just to highlight yet again that it's really important that all contacts are recorded, because I think we've probably had some cases where people were meticulously recording the first contact, but maybe not all contacts if the first contact hadn't been a face-to-face or video contact. So now record all contacts. Okay, if anybody has any queries of that, please do come back to myself or Jenny or Barbara as well. And we will also be picking this back up for the specialist teams. We've got access metric webinar in a couple of weeks' time, and we'll be picking it up in more detail then. Okay, next slide, please. So you'll have seen Jenny and I have been highlighting the first 1001 days movement over various webinars over the last couple of months. And so this is just a bit of background of the work that's been done to date. But if we move on to the next slide, I just wanted to highlight that on the 25th of March, the government published the Best Start for Life vision document, and that sets out the vision for the first 1001 days with the 6 areas for action. And we will be visiting or revisiting this, particularly in the June webinar, but I just wanted to highlight the latest information on this, and you have links so you can go and have a further look at it. Okay, next slide, please. So that was a brief national update this month, but without further ado, I would like to introduce our first speaker, Becky Burgess-Dawson, Clinical Lead at Health Education England. He's going to talk to us about the National Mental Health Programme and in particular the trauma-informed learning. I will hand over to Becky. Do we have Becky on the call?
I know she had some clinical work, Liz, so it's possible she hasn't quite joined us because
Jenny,
I think.
are you talking about me?
Oh,
I have literally just walked in the door. Colleagues, friends, I'm so sorry.
It was perfect timing.
Was it? Did I just saunter on then at the time? I'm so sorry. Do you want me to get right into it?
Do you need a couple of minutes, or would you? No.
No, I work like this. I'm a crisis practitioner, ladies and gentlemen, by trade. I work like this all the time. Next slide, please. I work for HE. If you don't know me already, my name's Becky Burgess-Dawson. I'm a mental health nurse by trade of 30 years. And since 2016, I've worked for Health Education England, who I'm ashamed to tell you I wasn't quite sure of before I joined what their remit was and what they did. But we're one of the arm's length bodies of the NHS. That means that we support excellent delivery of healthcare by our colleagues in NHS England Improvement and others by ensuring that the workforce is right, that it's in the right number, that it's got the right skills, values and behaviours. Thank you. Next slide, please. We're working in perinatal mental health care as well as other swathes of programmes of work in the adult space, older people, children and young people, lots of work going on there. But as you can see, or maybe you can't because it's too small, because there's so much going on, we're doing lots and lots of work streams related particularly to perinatal mental health care. And 16 work streams, I think, have been identified for next year. But last year, one of the big asks of us, apart from looking at the long-term plan ambitions, looking at e-learning, looking at developing various professions like medicine and nursing and AHP, one of the big asks from the perinatal space was, can you increase people's training in trauma-informed care? And that sounded a really sensible suggestion, but as lots of people on this call and I were immediately aware, that's a bigger change than creating a programme of e-learning. Next slide, please. Because there are components of a system that make up trauma-informed care. There's about realising, first of all, the widespread impact of trauma and what trauma is and isn't. There's about recognition, and that's a really difficult skill to teach. It's a really difficult competency that's really nuanced and based on lots and lots of underlying skills and values and abilities. But when you have that and you're able to recognise the signs and symptoms of trauma, it's about responding to it. And responding to it on an individual level is one thing, and again, perhaps the more simpler ask when it comes to education, but responding to it as a team or even more as a system, that's a bigger cultural ask. particularly because it's not just about the initial trauma or the responses to a series of traumatic events, it's about actively resisting re-traumatization. And that's especially true in our space, in the health and social care arena. And for us as professionals, being traumatized ourselves, but foremost, of course, for our patient group. Next slide, please. So because of that, and here's a lovely quote by Deborah from the King's Fund, this is about a cultural shift. This is not about a mere behavioural one. Behavioural won't be hard enough, it's not merely that, but a change in the way frontline staff understand all these things. I like that Deborah puts there, the highlight in red is mine, that training is a good place to start. And as we started to get together an expert reference group to discuss this issue, we realised that there may be a starting point before the natural start. Next slide, please. After saying that this was a huge programme of work requiring a cultural shift right across systems and processes and ways of learning, I then found myself being the biggest hypocrite ever and proposing to Health Education England that what we might have was some e-learning. But I meant something a lot different. I'm talking about a learning portal. I'm talking about a journey of learning for an individual that they can navigate themselves. We needed to split trauma sensitivity, trauma informed care, trauma awareness, trauma learning down into its component parts and make all of them safe, relevant and accessible for whoever wants to learn from them. So we needed things related to the content on the left there. We needed subject matter expertise first and foremost, our experts by experience, of which we have a swathe of people come to join us and freely give of their time to help us understand what we need to do, as well as the client group expertise of people receiving services. But also when I talk about client group expertise in HE, I also mean the health and social care professionals who were accessing the learning. We needed to design this in a slightly different way than some of our traditional e-learning. And I'm sure that you've engaged in our e-learning already. E-learning for healthcare, you may have done some of their training online. They're part of Health Education England. They've been around a long time with millions and millions of users on the portal. We needed something that looked different and that felt different. There was the cultural aspects of creating this learning meant that we had to have something bespoke. So to do that, we needed design expertise. Instructional designers and IT experts, as well as those preparing multimedia for us. And then to launch it, there's no point in building something beautiful if no one knows about it, no one can access it, no one reviews it, adapts it, modifies it and makes it suitable for their practice. So we needed our comms professionals to come join us as well. So that's what we did. We got together an expert reference group, of which I know Jenny is aware and kindly invited me to talk to you about it today. But we got an expert of all those professionals together. And we created what we're calling it a wireframe. I think it's on the next slide, please. Here we go. Daunting, no? Building it was just as daunting. This is version 5 of a document that you can't read because it's so vast, and that's why I'm showing you on a slide, because it is so vast. We've created a series of interactive learning experiences. We're proposing that each of them, none of these little buckets that you can see on the screen are full yet, but we're suggesting that there will be some interactive rich media that you can engage with wherever you are and whoever you are, but that it will be coupled with a reflective workbook to deepen the learning in the context of your practice. This, please don't confuse it with a pathway to enable you to do trauma-informed care. This is a learning journey, slightly different. You can go anywhere along this journey, picking up knowledge, skills and expertise that you can then translate, reflect on and use within your own practice to become more trauma-informed. It's split up into 3 sections that I think you can still see on your slide, even though it's tiny. There's a big swathe along the top that's coloured blue, and that's about your introduction to trauma-informed practice. That's about making you more aware of the potential, of the enormity of what you need to know, because the green section beneath it is what we think to be the bare minimum of the individual components of trauma-informed practice that are being described right now. And at the bottom, there's like a purpley section you can see there with some blue buckets in it. Now, that section is about specific trauma expertise. It's about trauma-focused CBT, EMDR, building trauma-sensitive environments. It's some very, very specific technical expertise, but they're all in there. And you can see they're graduated right from initial awareness through expanding your skills, right through to those individuals who wish to subspecialise in dealing with trauma specifically as part of their everyday practice. Next slide, please. I'm just going to show you the top section, the blue section you saw on the slide previous, because this one's really important. This is what we're working on right now, today. I've just been in a meeting early this morning about an area of this part of the learning journey. Because when we got the expert reference group together, what they told us very clearly from the outset is we need to understand human development first. We need to understand what human beings feel like when they're threatened and how they respond and how they attach to other human beings in relationships that can either be positive or not, and how that impacts on trauma, that impacts on them. And so at the beginning of that journey, you'll see there's a human development and responses to threat module, followed by what we mean by trauma, and that can be different for everyone, but there's something about being in the health and social care space and what you understand to mean by trauma. Then a basic awareness, a burgeoning basic awareness that you then have. So some of the concepts and some of the challenges that you then apply in your own life or where you work or how you work. Making trauma-informed approaches as part of healthcare is then the culmination of those things. But right back to human development and responses to threat, what we're realising as well is there's a whole public health agenda to this as well. We know, I know from personal experience that lots of people in my mental health career have talked to me about resilience, and they've kind of been referring to it in quite a derogatory way, that it somehow suggests that if I'm not resilient enough, then I can't cope with some of the challenges that trauma or threat will throw at me. And that's not the case, but there is something about one's own personal capacity to manage things and the environment in which you're allowed to be able to manage things, and you have time and space to manage things, is really important. So there's another module then allied to public health, and we have public health specialists who are helping us to construct that. So overall, each of these 5 pieces of learning are standalone in their own right, but they're also all connected to each other. They all have a discrete number of learning objectives related to them now, and beautifully, and I'm so grateful, they all have experts in the clinical field, experts by experience, editors who have specialist editorship expertise, and experts in review. They all have all of those things attached to each of them, and right this minute are preparing content that's not only on slides and in words, but also they're suggesting animations and videos and case studies and real life experiences and hyperlinks to other great practice, both around the country and internationally. It's a very exciting and very scary time all at the same moment. Next slide, please. What we intend to do then, after we've prepared this content and we've launched it and tested it and made sure that it is useful to the community, is having a look at where we place this skills building part of our wireframe. And we have to break it up somehow. We've got to give the learner some kind of appreciation of where they might like to go next. And the only way that we could envisage that is that at any point in our lives, we are going to be of an age, and we're going to predominantly care for someone of an age. That was the very high level overview that we took when we started to think about putting more modules in more places. So there'll be a perinatal pathway, a children and young people's pathway, working age adults, older people's, and development of services, a more strategic pathway, if you like. But these will all interplay and collaborate between themselves and each other along the way. For instance, we'll create some learning that tries to dig deeper into what might we mean by ACEs, adverse childhood experiences. What do we mean in terms of managing them when you're a child or young person and they're happening in the immediacy, but also how do they impact on you when you're older, when you're an adult or when you're an older person, even though they're related still to ACEs. So the ACEs module will be offered up to a number of these groups across the chronological timeline. Next slide, please. And then we'll go into some deeper learning in those areas. And I've tried to make the middle section a little bit bigger because I know that on the call, as people always are, you'll be desperate to know, is my special interest area in here? And I hope it is. Within these large areas, there are also 37 sub areas that are contained within one or more of these. So you will see, oh, the screen went blank halfway through, maybe just for me. But you'll see, for instance, there's something very particularly that we need to cover about learning disabilities and autism, and the special considerations of the special awareness for that group right across the age pathway. There's buckets about, for instance, my area of expertise, mental illness and disorder, but they're housed within other things. For instance, there's something about particularly mood disorders, but something separate about trauma and psychosis, because I know there's something about challenging over time people who may suffer from a psychotic illness that's often quite biomedically treated in health and social care. And there's something about practitioners and professionals and carers and relatives being able to reflect on, there's a whole biopsychosocial approach to being able to support somebody in that space. So that's why it's got its own bucket particularly. And at the bottom as well, and it's a learning pathway, remember, so it's not something to be thought about after the rest, but at the bottom of that pathway, there's immediacy of help and helping in times of crisis. And no matter what age, what service, where you come from, what's happening, there's something about the immediacy of response that I think is especially poignant at this time in our lives, as we get into this post-pandemic space where everybody understands what it means to feel traumatized. Next slide, please. So what I want to do today, because I only have a short time with you, is to introduce you to some key contacts. On the right hand side is a really key email address. If you put in the subject header the kind of thing you want to discuss, then anything related to learning and development, education and training in mental health in England can go to that email address. If you put trauma, for instance, in the subject title, then the mail will be forwarded to one of us for your answer. And it depends what kind of question you have. If you have questions about this presentation or questions about HE generally, if it's about the organisation of our work strategically, then I'm sure Emma Scales, our delivery lead, will be happy to help you. I will be happy to answer questions related to clinical practice or related to educational expertise, because I have expertise in the teaching and assessing of health and social care professionals, and that's why I'm in the clinical lead job for HE. Julie Taylor is the manager of this particular project, but she also manages some other business now. She's now business lead for HE, but she's managing this particular wireframe. As you can imagine, quite the ask. And Jeanette Hughes, our project officer, for all the day-to-day arrangements of meetings and scheduling and garnering other expertise. So they're the team. It's not just me, by all means. Contact any of us, but the email address on the right, I hope I've left the slide on long enough if you wish to get in touch with us in the national team at HE. Thank you, Jenny, for inviting me. Because I've been looking intently at the slides, I haven't been checking for questions. I don't know if anybody's got any for me in the immediacy. I really appreciate your time inviting me.
Oh, Becky, thank you so much. I know that you've got another clinical appointment at past, so if anybody has got questions, quickly for Becky.
I notice Anna's put in the chat box, how remiss of me, there are a number of regional leads around England, and in your area particularly, you've got Anna as the regional lead for us at HE. Anna, I'm so sorry, these aren't slides for this region specifically. I'm so sorry, there are national slide sets, so how dare I? Anna, do you want to introduce yourself as a member of our team and a colleague of mine?
I think so. I've been the perinatal lead for a number of years, Becky, so across Wessex and Thames Valley. So I think most people know me, but
good.
And if they don't, there's my email address there.
Wonderful. Thank you so much, Anna.
And
Anna, you'll probably realise we're on your turf.
People on the call that could pronounce the name of the new Welsh unit for us as well.
Yeah. Yes. I haven't got it in front of me, so I can't do that, Jenny. Maybe at the end of the call.
Shame. I have a burning question, Becky. What are the timescales for it? I can't wait for this. I just can't wait. I think it's been, you know, we need this, and we need it right now, don't we, with everything that's going on?
Yeah, and I'm having another meeting today. The first 5 modules are pending going to instructional design. So that means that the authors have written content on a Word document, and they've put insert video here, consider animation here. This will be a good case scenario for a workbook. So they've got their 3,000 or 5,000 words, like an essay. So at the moment it's going to instructional design. They tell me at eLearning for Healthcare that we're talking now a number of weeks before those are ready. I need to check that out in some more meetings this week. But they're telling me what they'll do then, they'll liaise with the authors and negotiate which is the best way to show this piece of information for maximum experience for the user. But I'm fully expecting within a number of weeks to be coming back to you, asking you and your group to test out some of these early modules and let us know that they're useful. Yeah, before we make some final refinements. Yeah, so I haven't got a date for you.
There'll be loads of people, I'm sure, on the webinar that would be up for that. I certainly would be.
Oh, brilliant, because we're going to rely on that. If it's not useful for practice, then that's a drum I'll always bang as a clinician. I want to be able to go to my clinical shifts on the shop floor and hear people talking about the stuff we're creating here.
Yeah, and there's some people coming through in the chat already saying they'd be interested, and so that's fab.
I might be really cheeky, Jenny, and ask and come back to you when we're ready for some user testing. I might come back to you as a point of contact, and Anna, because you're in the area.
All of the webinar attendees now, but I think we'd be fine to do that actually. Yeah. So yeah, that's brilliant. Sorry, there's a long question in the chat.
I'm just reading Diane's question, Jenny. Yeah, and this is the reality of services. You've got someone who you know requires specialist expertise, but it's about how you manage in the immediacy between services. And I was in clinical practice the other day, and there was a client who had lots of specialist trauma services and was in recovery but was experiencing difficulties, and it was about not us providing specialist expertise but having an awareness of the treatment that had already been delivered and what could be possible. And now in terms of waiting lists and services that are put in place and the treatment people access, I can't make comment on that because I'm not from a provider of services. I'm from a training of the workforce to enable them to work in services point of view. But yeah, but on a personal level as a clinician, I know exactly what you mean by that.
Brilliant. Yeah, I'm mindful that you've got a clinical appointment, Becky, so I've got loads of questions, but I'm going to save them. But thank you so much. I don't think this could be more timely for perinatal with the advent of the maternal mental health services and all the different asks of the long-term plan. I think for, you know, stakeholders across the whole perinatal pathway, this is going to be amazing. So yeah, really looking forward to it. Thank you.
Jenny, thank you for the invite. I'm sorry to run in and out, but I couldn't resist the opportunity to come see you again. Thank you, everyone. Lovely. Thank you for listening. Please get in touch with me.
Thank you.
Thank you.
Thank you, Becky.
Bye.
So that was a lovely start to talking about our theme today of care leavers, and we felt that it fitted well into today because of course the trauma and care leavers go hand in hand. So I'm really delighted now to introduce Mark. I'm not sure if it's Riddle or Riddell, Mark, so sorry about that, who is the National Advisor for Care Leavers, and I've spoken to Mark about his presentation, and I think it will give us all a lot to think about. So I'm going to hand over to Mark now. Thank you, Mark.
No, and you know, thanks for that, Jenny. I think it's the different places you pronounce my name in different places. So Riddell's usually the right pronunciation, but because I've got a social work background, as a qualified social worker, I've been called a lot worse over the years. No, so thank you for inviting me to come and talk to you today. I mean, it's it's a fairly important time for care leavers in relation to not just the pandemic, but certainly the offer that we offer care leavers. So in the context of why I've got the job, I mean, I've been in social work for probably around 30 years. And, you know, I have personal experiences of the care system growing up in the northeast of Scotland, you know, from the late 70s to the early mid 80s. And, you know, my history of going into care was my dad was an alcoholic, and my mother was subject to quite extreme domestic violence over a number of years. And eventually, you know, she died, you know, of various health complications. And that led to us moving around families and ended up in local authority care. So being a national advisor puts me in a fairly good position to understand the stuff that Rebecca was just talking about trauma and where young people come from and resilience and emotional well-being. My history, again, you know, I wrote about my experiences in a book called The Cornflake Kid that is still available for professionals and for young people, and it still sells today because it's one of the first autobiographies written by someone who had care experience. So I come to the job as a national advisor with a lot of ambition, a lot of passion, and a wealth of information of 30 years of working in social care. So the three things I want to talk to you particularly about today is around about the legislation that we introduced in 2017. And, you know, I was a manager in a local authority in Greater Manchester called Trafford. And in 2015, you know, I arrived there in 2012 and I spent 4 years trying to understand what corporate parenting was. And, you know, I'm not sure if I like the terminology corporate parenting because I think it talks about a business and how does that relate to parenting. So I always use a bit of a strap line after that a less corporate and a bit more of a parenting approach would be nice. So when we got the outstanding in 2015 from Ofsted, one of the things that came out of a very strong feature in the Ofsted inspection and what young people talked about was about us being good parents. So everything we did was based on, is this good enough for our child? And I think the key second bit was that we worked really hard with our local offer, which I'll talk a little bit about, and where health fits into that local offer. And then the third thing I'll talk a little bit about is where health sits, and not so much just perinatal care, but I'll talk about a general health offer for care leavers. And, you know, we'll talk a little bit of what a health offer could look like to improve the lives of our care leavers. Can I have my next slide, please? So my job essentially is to work across the whole sector, and that's predominantly local authorities, but that doesn't exclude not working with clinical commissioning groups or NHS England or other delivery partners like DWP, housing, and the business sector. So in the first 2 years, just before the pandemic, I'd visited around about 40 local authorities on a formal visit of consultation to see what they had offered to care leavers was. So I visit local authorities that are inadequate and require improvement, but I also go and see the good and outstanding to see some of that good practice and to share that good practice across 153 local authorities. I attend 9 regional forums. There's 9 regions within England that I attend and try and get a bit of a sense of what happens in the northeast compared to what happens in the southeast and the Midlands and what happens in London, because those demographics mean sometimes different responses to our care leavers. I work closely with the local government association, the Association of Directors of Children's Services and Children Care Alliance, and other third sector groups like Become and other charities and third sector organisations. I try to meet with care leavers in every local authority that I visit, and I suppose in the last 2 years I've spoke to around about 400 care leavers, which gives you a wealth of information and knowledge about how they feel about either the corporate parents or the local offer and how they're being supported into either a transition or into adult living. And then the last bit really is to work across government to strengthen their offer to care leavers. There's no point of us trying to push things at a local level if at the government level that the policy is adverse and it doesn't favour care leavers. We've got a care leaver ministerial board that's been set up, which I'm attending, which I'm a member of. Michael Gove is the chair alongside our Secretary of State, and that's where we've pulled government departments into that meeting and hold them to account about what their offer is, either from DHSC or from DFE or from DWP or MHCLG. We begin to question some of the policies that are around that maybe are not having the greatest effect for young people locally. Next slide, please. So the key things I'll talk about today is a good corporate parenting approach, a model of delivery and an offer to care leavers up to 25. Next slide, please. Okay, so in everything we do, I mean, this is probably just something as a background slide. I would hope that certainly that if we're doing something in any way that we work, whether that's health or social care, adult care, or in housing or in DWP, is that we look at something, a policy that we've got, an approach that we've got, a delivery that we've got, and we have to say, is that good enough for my child? If my child was to come into care and to become pregnant and become a single parent and was to leave care, are we offering the right level of perinatal care, the right support, the right emotional support, the right health support, the right housing support? And if we think it's fallen a bit short, then we've got to ask the question, then why are we doing it? You know, we need to push that to the highest level and say, you know, for example, in housing legislation, if a care leaver makes a mistake, or if any young person in social housing makes a mistake because they're not ready to live in social housing and they leave that property, the local authority can deem them as being intentionally homeless, which is a bit of a nonsense because we don't make our own children homeless. You know, so we've got to ask ourselves, is that a policy that needs to be changed at a local level, for example? Co-production, we hear from many young people that they're not involved in the offer. It's not been driven by their experiences, not driven by the voice, and certainly not leading to significant change. So co-production is really, really important about hearing the voice and making sure we tell the stories of those young people. Agree some outcomes. Again, be ambitious. I mean, I'm always ambitious in everything that we do. If you feel that, you know, that you're looking at a policy and it doesn't go far enough, then we've got to say, well, why are we stopping at step number 3? Why are we not heading towards step number 5? Be a lifelong champion. I mean, the care journey and leaving care is a journey, and young people will make mistakes and they'll make different choices. The message we should give them, like we do with our own children, is if you take a wrong turn, we'll get you on the right road. And does a leaving care model work? And I'll talk about what that means for health. But essentially, when I'm talking about a leaving care model, I'm talking about the leaving care offer from the local authority. So that should be a 16 to 25 offer. And what we're trying to do by including that in legislation, the local offer, is that we begin to see young people who are moving towards a leaving care relationship, maybe around about 16, that they can have a relationship with a personal advisor for the next 9 years. And that seems to be what young people wanted, was longer term relationships. So they're not continually telling the story to other professionals when that professional leaves. And then I think the final bit really is about, are we joined up enough? And I'll talk a bit about that in the corporate parenting slides, and who's sat in the room. So if you're not sat in the room talking about care leavers and the perinatal offer or the health offer or the emotional well-being issues, then who is sat in the room talking in a joined up sense to people that deliver services? Next slide, please. So a good corporate parenting approach, again, you might think, well, where do we fit into that from health? Well, actually, many local authorities are beginning to push that they will have potentially, say, 8 boards a year. 6 of those boards will be theme boards. So they'll have a particular theme. So one might be around homes for children in care and care leavers. One might be around health. One might be around finance. One might be around, you know, business. One might be around education, employment, and training. So some boards are beginning to look at theme boards, and health will certainly be part of looking at where is that within a corporate parenting approach, because the new duties that come in 2017 apply to health as long as they do as close to social care as well. So it's exactly the same corporate parenting duty that's placed on you as it is on the local authority. So some other boards will celebrate success, and then they'll maybe have one meeting that looks at data. I mean, I've been to boards, probably hundreds of boards in the last sort of 30 years as a worker and as a manager. And many boards sit down with elected members, officers on one side of the room, members on the other, and they look at a 35-page report that talks about data, and they don't really see the stories and they see the successes that the offer is coming from different agencies. Elected members become champions. So you might see a champion for health. So that might be somebody who's an elected member who's got a history of being a GP or working in health services for the last maybe 20 or 30 years. So them being a champion is really important. And how they link to the operational bit is equally just important, because we want those stories of young people with lots of housing issues, being made homeless, a CAM service disappearing, maybe as young people turn 17, and they weren't ready for a CAM service, but they're not getting offered a CAM service post 18 because it doesn't exist within NHS. So they can feed those stories up to the operational champions, and that gets taken back to the board for the elected member to discuss. But why don't we have an offer to care leavers from a health point of view, 18 to 25? So the stories, they are presented, and you'd expect the boards to sit down with all the different delivery agents and begin to resolve those approaches with a favoured approach to care leavers, but also based on that thing that I said before about, is this good enough for my child? And the success of who's sat in the room. So if you're not currently sitting close to a corporate parenting board in your local area, you need to find out who is sitting on the corporate parenting board, because there should be cross representation. So DWP, YOS, probation, police, adult and mental health, housing, and vets from business. And I say it's important, that point number 7, because if you was to go to a child protection conference and the police hadn't turned up and the social worker hadn't turned up, it would be totally inappropriate. There would be hell to pay for. So you would expect people to be in those multi-agency meetings and multi-agencies to be represented. So if you're not sat within a corporate parent, find out who is, from a health point of view, going to the board and talking about what you offer as a health service. Next slide, please. So a model of delivery for health. So the local offer I've talked about is a 16 to 25 offer to care leavers. So there should be a section in there regarding health. Now, a lot of local offers that I look at will say under a health section, we want young people to continue to be healthy, and we offer some sexual advice from a clinic down the road, and we offer some counselling from your GP down the road. You can get access to your GP down the road. And sometimes that general stuff is okay. But we want to know, the care leavers want to know, what's the finer detail of it? So in the health offer, if I don't feel well and it's related to my experiences of childhood trauma or ACEs, or if I'm pregnant, what am I going to get from health? So if I do fall pregnant, am I going to get a health service? And again, Rebecca was talking about not revisiting trauma again and not expecting care leavers to tell somebody their story again and again of why they've become a care leaver. So there should be a section in there about general health. And if there isn't, have a look at the local offer in your local area. Every local authority has a duty to produce one over 2 years ago. So there should be one available to have a look at. And you'll be surprised if you look at it and think, well, where's the bit that I do? Where's the bit that I offer? Where's the bit about GPs? Where's the bit about emotional well-being? Where's the bit about single parents, both mums and dads? Where's the bit around emotional well-being? So have a look to see what's in the local offer. Transitions to adult and mental health should also be in the local offer. And some of the good practice that I see is that we're beginning to see local authorities beginning to involve transitions to adult, not the workers potentially coming in when young people in care are 14, but beginning to build up under the health section of the care plan, beginning to build that up so that we can produce information to adult services and to mental health services as young people move towards those thresholds when they're 18. So we can begin to build up a real picture of what young people may be able to do or not be able to do as they become 16 and 17-year-olds. And that's asking questions like, can they make a best interest decision? And you might say, well, at 14, we're not so sure. For some young people, you'll say, yeah, they can make best interest decisions, no problem at all. But there's some young people that you probably go, I can't answer yes or no to that yet because I'm just not sure yet. So you look at it when they're 14 and a half, 15, 15 and a half, 16, and you begin to build up what that looks like, capacity and best interests. And we've got to do that sooner. There's no point of asking those questions 2 days before a young person turns 18. It's far, far too late. The health assessment, again, I know there's work going on, certainly within DHSC around the health assessment. And again, I want health assessments when young people come into care, it to be, a really generic health assessment with a real focus on why you've come into care and the particular issues that will need to be looked at over the next maybe 7 or 8 years. Not just the issue of why you've come into care today and about stability, but more about this is going to affect you because you've come into care because of some sort of trauma. This is going to affect you for the rest of your life. And that health assessment should really follow care leavers all the way to 25 and should be used as a way of reviewing it every 6 or 12 months within the either LAC process or within the pathway planning within leaving care. Joint assessments, again, when young people turn 17, again, I don't see a lot of that, although I do think we should do more of that, certainly with specialist agents, certainly with adult transitions and for mental health, especially around thresholds and being access to adult services and other services. So a favoured approach if the threshold is just not met. So young people below the threshold, we've got to think about, so what's our offer to a young person who has come into our care because of emotional well-being, because they were sexually abused, say, for example, as a child, and they've settled into foster care, and they've moved out at maybe 19, and they're cutting their arms, and they've got emotional well-being issues. What threshold would they meet? They're probably unlikely to meet a mental health threshold unless they were standing on a bridge and this was the 3rd attempt and they try to take drugs and alcohol and other stuff. But a lot of young people just feel unwell, and to hurt themselves is a way of getting rid of some of that pain that they feel. So the favoured approach, just below threshold, we need to think about what do we do to those young people that have got really high level of needs, because if we don't do something, they will probably likely in a few months or a few days or a few weeks or a few years, they might meet the threshold, and then we're into really high cost interventions, which we could have prevented a while ago. And then the final point really about a good model for delivery for health is to share the adult and community resources. There seems to be sometimes at play that children's is one area and adults is another. And we've really got to think about not giving resources, but sharing what those resources have that they can offer to our care leavers. Next slide, please. So a health offer to care leavers. So this might be something that you're very familiar with. And again, this is what I've seen in the sector. And we've got to think, is this the bit that we're thinking about? Is this good enough for our children? So CAMSEM's at 18, and I know there's a long-term plan, and I know there's a not to death plan in place, and they're thinking about care leavers and a not to 25 trajectory. And the CAM service may change, but I'm not really convinced that when you're 19 that you want the same as a CAM service when you're 13. There might be components of counselling, mindfulness, other types of therapy that might be more important, that isn't done predominantly just by a psychologist or a trainee psychologist. So although CAMS does end at 18, there should be something else that's very specific to care leavers up to 25. So LAT nurses fall away usually at 18. There's lots of LAT nurses that I speak to that try to keep on board with young people for a little bit longer if they've got some health needs. But traditionally they fall away at 18. So those two things are something within national policy we've got to think about either changing or giving additional resources so that LAT nurses can work over 18 and we can offer something to care leavers over 18 from a health point of view. Health needs are usually met through mainstream services, which is fine if you can get a dentist or if you can afford a dentist or if you can get a GP in your local area. Then sometimes it's good luck, care leavers, and off you go. And that can be really quite challenging depending on where you live. Complex needs, again, really high thresholds and eligibility, which leaves a gap in provision. DNAs, again, I hear lots of cases where young people have got professional anxiety. They don't want to go to another professional in a different office and to tell their story again and again and again because it is traumatizing. So they won't go to appointment to see the adult transition worker or a mental health worker. And the DNA, the appointment is taken off and they're put back to the start of a waiting list. What should really happen is there should be a communication between whoever is offering the appointment and the personal advisor to find out the particular issues that are around that young person's DNAs. And does it mean that the worker has to go and visit the young person in their house or in the leaving care office with support from a personal advisor? So there's great opportunity to think about DNAs. No real sharing of roles and resources, which I've talked a little about. And what about emotional needs? Who pays when a young person has emotional issues related to their experiences of coming into care? Not necessarily their clinical need. So NHS England will say, if you break your arm, then we'll fix you. But if it's emotional or behavioural, then that belongs to somebody else. And I would disagree saying it belongs to both social care and to health. Next slide, please. So a few examples, just before I end, a few examples of what local authorities are doing. Many do extend their nurse provision to at least 21, and that's been difficult to achieve. But I think it can be done. Not saying that you'd extend that for all care leavers. So if you're a local authority that may have young people who are care leavers between 18 and 21, you might have 150 of those. And you'll probably find that the percentages of young people that want that LAC provision is probably maybe 5 or 10%. So we're not talking 200 care leavers that want that service. You might have a handful of young people. So we're not talking a massive implication on resources. We're not talking it's a full caseload, but it may be 5 or 6 young people that just need a little bit of support for a little bit longer. So a favoured approach when below thresholds, what would be good to see would be that services, for whatever reason, intervene for a short period of maybe 3 months and then decide whether a longer term intervention is needed. So I'm not saying you offer an adult service and you offer it for the rest of their life. If they're below threshold, you could say, okay, so they've got a high level of lead. Let's just get in there and do a bit of an assessment and just see what we've got and see what we can offer. And if we can't offer anything, then we can step it down. But you'll probably find in many of those cases that there's probably something you would be able to offer. So that 3-month period would be good to see. And I've talked to NHS England about how we could do that in the long-term plan. CAMS offer, again, we've talked about how important that is. I do see some psychologists and leaving care teams who can then connect young people to very complex pathways into adults or to mental health, which works remarkably well, and connect to other people like speech and language and other types of therapists, and they know the industry remarkably well. I do get a sense of, and not again, I don't see a lot of it in local authorities, but I have seen adult and mental health practitioners, specialists in leaving care, so that young people walk in and they can begin to talk to a practitioner without having to do a referral, to send it to another office, to get to the other Pennine Acute Trust in Manchester or whatever it is. They come into leaving care and say, can I speak to the mental health worker because I'm not feeling particularly well today, especially around that emotional well-being aspect. And it'd be good to see emotional well-being workers in teams. And again, the bit that I push for a lot of times is free prescriptions dental prosthesis and glasses. And I'm talking to NHS England about that over the next couple of months. Because in the Greater Manchester local authorities, the Greater Manchester 10 was made up 10 local authorities. They've got a care leavers trust, and they've agreed that care leavers up to 21 will get free prescription. So if you're on a low wage of £160 a week on an apprenticeship, for example, and it's the middle of December and you've got rent to pay, which is £90, and you pay your bills and you've got £10 left, and you go to the doctor, you need to write you a prescription for £9 because you need it from a health point of view, and you're on your last £10. You have to make a choice of either paying for gas and electric or food or your prescription. And care leavers tell me that they would probably go with the gas, electric and their food. And that's a horrible thing for our young people as corporate parents, for us to hear that you have to make a decision about either health or eating or living on a day-to-day basis. So free prescription doesn't sound like much, but it's a massive difference to care leavers. And there's a lot of young people who are already exempt, certainly if you're not in work and if you're pregnant and stuff like that. But it's the care leavers on low wages where they've got that free prescription, certainly in Greater Manchester, up to 21, and we're hoping to get that pushed to 25. And then the DNA approach, again, I've talked a little bit about that. And I think all the stuff that I've talked about above will save money. And when I say save money, you know, it will save huge interventions a bit further down the line, all of what we're involved in. And it just means that easier for care leavers to access when they know exactly what the health offer is. They know that they won't have a DNA approach. Okay, so I get a free prescription. That's really good. And if I don't feel particularly well, then I know I can come to Leaving Care and talk to somebody who knows about my experience. So I don't have to tell the story again. Next slide, please. So that's really what I wanted to talk to you about. So I hope that's been useful. I'm happy to take any questions. I'm over 50, so following people on the chat bar and the questions is probably outside of my reach in some ways. But if anybody's quite happy to take questions or anything that anybody's interested in making comments about.
Thank you so much, Mark. Oh, I'm echoing. It's a bit off-putting. I was going to say, sorry, I've got a dreadful feedback on this. I'm just going to switch my sound off to mute and back on again, see if it works any better. Hang on. Okay. Oh, it's not much better. So yeah, I just wanted to say a massive thank you for that, and it's just so thought-provoking, because obviously we do come across care leavers in all aspects of the perinatal pathway, and you know that they come from a background of complexity, but when you really start to think about the other obstacles that they're up against, that expression that you used, which I shall be stealing, about having a favoured approach to them, and maybe thinking flexibly about your own thresholds if you have somebody who is a care leaver referred in. I think that's a really compassionate thing that we can all do, because, you know, just hearing your talk, they're just so up against it, aren't they?
The bit, Jenny, that's really important is, and I get asked questions all the time about, well, why don't care leavers, when they get to 18 now, why don't they tell us they're a care leaver? And what we have to do, we've got to talk to young people when they're in our care, so when they're a child in care, and begin to say to them, look, you know, you will come across services in the years to come, but we've got to tell you what we offer. So one example I'll give you was that a young person who was going to custody, and you know, when he looked at going to custody, he was going to get treated like every other prisoner going into custody, and you know, rightly so, he'd committed an offence. So he said, why should I tell the prison guards, or why should I tell a support officer in the prison that I'm a care leaver if I get treated the same as everybody else? So we've worked really hard on thinking, let's give them a favoured approach. So long before they even get anywhere near prison or a secure hospital or they hit mental health, we need to say to them, it's okay for you to say that you're a child in care or a care leaver. And we won't necessarily get into the detail, but it's okay to say that, because when you say it, this is what you're going to get instead. You're going to get a different approach. Okay, we won't treat you softly and all that sort of stuff and all that sort of stuff, but we will say to you, thanks for telling us that. Thank you very much. And there's the stuff that we'll give you, because we know that care leavers fit into every vulnerable group in society. You know, they're the group that fit into custody, unaccompanied young people, mental health, adult social care, transitions, the homeless section. They fit in everywhere, Jenny, to be honest. So I think there's something about what is the favoured approach, and we need to tell young people what that is long before they become parents or single parents.
And there's an interesting question which I'm not sure if you can answer. I can't answer it, so I might have to look to colleagues on the call. Are there any examples of good practice around care leavers accessing perinatal mental health services? So yeah, I'm just wondering if you have any examples of that specifically, Mark, which is quite a hard one, I guess, for you to answer because it's quite specialist.
Yeah, no, I've seen, I mean, I don't see a lot of it, to be honest with you, Jenny, but I do see in Stockport, for example, I mean, they work very closely with their family nurse partnership and work very closely with sort of, they've got a number of health workers in their leaving care team. Now, where they've got the money from, you know, I'm not sure whether it's social care money or health money. And that bit seems to be the bit that gets in the middle of who's going to provide those services, which I talked a little bit earlier on. So there is some good practice. But when you're talking about 153 local authorities, I'd probably say I see a good approach, you know, sometimes to, you know, certainly perinatal care. I see that in a handful of local authorities. So it's not very strong. And I think that goes back to my point about health in the local offer and beginning to get that offer on the agenda and beginning to push. Why have we not got that perinatal services included in the health offer in the local authorities local office? So it's very patchy, to be honest with you, Jenny.
And we know that these young women are very vulnerable to having pregnancies, aren't they, to becoming pregnant, where they're like risk takers and that sort of thing. We have got lovely Fiona from Family Nurse Partnership speaking directly after you, Mark, because I think it's really important that people know about the fabulous contribution that Family Nurse Partnership make to this group of people. And Lucy Ellis from the Perinatal National Team has put in the chat about the importance of us thinking about this group of women in our work. We've got some new expansion going on within perinatal services, and we're really, really keen that nobody gets left behind. And I think this is a group that we need to really think about. So if anyone's got good examples of how they've worked with care leavers, we'd love to hear about them. And then we've got something from Rachel on the Isle of Wight saying she's had issues accessing support for under 18 who are looked after children and pregnant.
Yeah, and I think
perinatal services shouldn't not work with people that are under 18. But I guess if CAMs weren't involved, that was another conversation, Rachel. But that example isn't great, because that is somebody that absolutely should have been able to access the service. So if that's somebody that's still around, I don't know if it's an old example or a current one, but we'd love to sort of put you in touch with the right people if that's a live example.
Yeah, and I think that's the point, Jenny, I was saying earlier on about the local offer and delivery of services to care leavers. You know, we need to get away from the cliff edges of 16, 18, 21, and even potentially in the next couple of years to think about what about care leavers or care experienced young people over 25. You know, we don't end our parents with our own kids at 25. We continue to support them for a lifetime. So there's something about that. I think when I said, and again, this isn't a disservice to anybody on the call or anybody nationally. And when I said it's quite patchy, there will be some exceptional practice going on, Jenny. There will be some great practice, and people will be working very closely with young mums to be and young mums who've got their children, and there'll be excellent stuff. But I think the point I was trying to make was really about, it doesn't come out strongly sometimes where you see that joint partnership arrangements within health and within social care. And I think that's the bit we're trying to do. So if you're sitting on the call going, well, we do this and we do that and we do this and we do that, well, let's get it into the local offer. Let's tell our young mums about it. Let's tell our dads about it. Let's tell our young people who have got emotional issues about it. Let's get it on the local offer, and let's be accountable for what we do offer, rather than doing it in the background and never getting any recognition for it, because that will be some really great practice around.
Brilliant. Thank you, Mark. We'd also love it. I don't know if did you say you can't use chat? If you could put the details of your book in the chat, that would be fab.
Yeah,
lovely. Okay. So I'm going to now introduce Fiona Butt from the Family Nurse Partnership, because obviously this is an organisation that works very closely with care leavers who become pregnant, and we thought it was a really important service to hear from. So following on with our hello, my name is, here we have Fiona from Family Nurse Partnership.
Hi, thank you, Jenny, for that introduction, and thanks for inviting me. It's a really good opportunity. I'm sorry I haven't been able to be here for the whole call. I had something else came up this morning that I couldn't get out of. So for those of you that don't know, I'm going to do a little bit of an introduction about what Family Nurse Partnership is, and I've already seen in the chat that some of you will know that there's been some challenges around decommissioning Family Nurse Partnership services across the country. So that has been the case in Hampshire in the last couple of years, but actually we feel as if we're in our current position quite good in terms of security, because we're part of a 0 to 19 contract, which is really focusing on vulnerability. So as it sits within the rest of 0 to 19 services. Can I have the next slide, please? So the Family Nurse Partnership is a licensed nurse-led intensive service and about prevention and early intervention, specifically for young parents. And it started in the United States, and it started in the criminal justice system, really looking at what is happening in the early lives of young people whose trajectory leads them into crime and antisocial behaviour, and rather than thinking what do we do then, what do we do about changing things early, and so it's really focused on reducing the impact of multiple deprivations and improving the short and long-term health not only of the young people who are pregnant but also their children going forward, and focused on vulnerability, of which care leavers are a big part of the work. It's a change programme, so it's about facilitating change for that young person, because, and we'll talk a bit later about how that they might present sort of to us and their life experiences that have got to them to that point. But actually, in the case of working in a long-term therapeutic relationship with a family nurse, it's about trying to make change. Next slide. So those that are eligible for working within the Family Nurse Partnership Programme have to be having their first child. They can potentially have had a miscarriage or a termination in the past, but this would be their first pregnancy. So we don't work with somebody who's previously had children removed. And the reason for that is because the research around FNP is that it's the opportunity that a first pregnancy brings for change, alongside what's going on for an adolescent, that can make the change. To be able to establish a relationship and to work and to build that up, we have a license to recruit young people to work with us by the time they're 28 weeks pregnant, and the only exception to that is for concealed pregnancies, and we will, through recent changes, when I first started doing this, we couldn't do that, but we will work with somebody who has had a concealed pregnancy. Our eligibility criteria in Hampshire is that we offer the programme to all young women who are 16 and under, and then above that, if they're 19 but have been have been looked after, or history of being on a child protection or a child in need plan, or recent care leavers, we will prioritise them if they're older than 16. Also, if they have a learning disability, as I've mentioned, concealed pregnancies, and up to 24 with additional vulnerabilities. But the capacity within the team means that we're unlikely to take up that. We have done in the past, but not more recently. Next slide. As I've said, we're part of the 0 to 19 service within Southern Health, which is includes in health visiting and school nursing services, and that's the website. We have a team across Hampshire, so we are able to take young people onto the Family Nurse Partnership wherever they live in Hampshire, as long as they're living in Hampshire, and our neighbouring services are Southampton and Portsmouth, who also have FNP teams as well. So as 9 nurses, 9 family nurses, myself and a quality support officer serving the whole of Hampshire, with limited, we have license agreements about numbers of caseloads, so we cannot take everybody, but we will prioritise according to need, as I've just described. So yeah, caseloads are limited for a full-time person with 25 families, and that's to reflect the intensity of the relationship and the work, but also the level of vulnerability and the travel across the team. But we work very much alongside the rest of the 0 to 19 services too. Next slide. Thank you. So when I was thinking about this, I was just thinking about a young person who might have been in care, but also thinking about what's going on for young people during adolescence. And the definitions of adolescence from those 2 dictionaries are very, very broad. And I think the learning of the kind of understanding about adolescence is that there's a really wide range in terms of age, in terms of what we mean. And I might potentially argue that some of us never reach that threshold of becoming an adult. So just thinking about it, it's very broad and it's very very general. Next slide. And this is really slightly tongue-in-cheek, but maybe helping us to think about, whilst we've got a young person who's in care, they're also going through all the changes that adolescence brings. So you may not be able to see that in a huge amount of detail, but just thinking about that impulsive frontal lobe decision making and what's happening on the day being what's the most important thing. So and actually being able to plan and be logical and stick to appointments and all that sort of thing can often be a real challenge for an adolescent generally. And you add that in as somebody who's had a lot of experience of the care system or different services and finds it difficult to trust and make relationships, that can make it really, really challenging for them. And we've got the whole elements of risk taking and looking for reward, so that sort of and add that into the mix, somebody who is pregnant and planning to become a parent, it can be really challenging for them, and therefore we need to really think about how we work best to engage with that young person. Next slide. So you will probably know about a lot of this, but really thinking about that risk. And Lawrence Steenboat talked about a teenager, an adolescent's brain having a well-developed accelerator pedal. So really going ahead, moving forward, wanting things to happen now, impulsive, but not having that restraint, not having that being able to put a brake on and think, okay, is that a reasonable, rational decision? And that's around what's going on in their developmental stage. That's not necessarily personality, but that will add that into what their life experience is as well. And they experience really, really high emotions, which can be overwhelming at times. And then that may lead to behaviours which we find it difficult to understand, or we might find it difficult to work with. So what we try and do is come from a place of recognizing what's going on and working with that, and but also trying to put some sort of boundaries in terms of working relationships as well, and we'll come on to that. Next slide. Thank you. So really important to think that it's not that adolescents are unable to make rational decisions, or that they can't recognise the difference between right and wrong, but it's a real challenge for them, because they tend to work and make decisions on a gut instinct, rather than necessarily thinking about the consequences of their actions, but also thinking those through in a logical way. And we've also got the experience of peers and pressure from outside, and the pandemic has clearly heightened the pressure in terms of young people's mental health, and for any young person going through education at the moment. But for those who may have had a very poor experience of education through being in different placements or having been in care, a lack of service provision, and also a lack of role models potentially for a lot of their life, but particularly in their early lives, that can make things really challenging for them. Next slide, thank you. So I think we get a picture as I talk through this. So there should be a picture of a meerkat coming up, if that will work with the presentation. So really thinking about the young people, and we see this a lot in the young people that we work with, and often their partners who've had poor experiences in their childhood, who may have been in care. They can be really dysregulated, and their amygdala is more reactive, so that they react very quickly, and they can find it very, very difficult to trust and to concentrate. And this hypervigilance, we know that adolescents, one of the things that we do as a service is deliver some training in the adolescent brain, and one of the things that's in that training is really looking at how in all adolescents they're heightened to what other people are thinking about them, about themselves, and comparing themselves with others as part of that developmental stage. But for young people who've experienced trauma or abuse, they can be really, really hypervigilant, and therefore making relationships with people, particularly professionals, can be really difficult. And they can be, if they're feeling isolated or lonely, they may not understand regular social cues that others might, or they may need extra help with that. Next slide. The positives around adolescence, and that's what the FMP research is sort of based on, is that, as I've already mentioned, it's a time of great change, which has potential but also vulnerability, and because it's reorganizing and rechanging and pruning things in their brain, losing things that they don't need and learning new things, that's where the opportunity for change can come. So that fits alongside regular exams taking place, pressure. There's all the stuff emotionally around adolescence, but actually it's a place where the brain can take in lots and lots of information. Next slide. So with all that in mind, that sort of thinking about where an adolescent might be in terms of their developmental stage, but also where a young person who's experienced trauma or abuse or has been in the care system may be coming from, we really think very, very hard about engagement with our young people, and we know that a lot of the clients that we work with have had poor experiences. Professionals, they may have felt left down, they may not understand the whole process of what's gone into leading to them to them being in care, and therefore developing a long-term trusting relationship with a professional, which is what our expectation is as a service, is a real challenge for some of our young people. And therefore we need to really think about the best way to engage with that young person. And so we have the way we work is about being strength-based, that whatever the situation, even off on paper it can look really, really dark and dire in terms of the risks to that young person or that unborn baby, that we try and find some strengths. And I reflect quite often on hearing conversations of my team when we really first started doing this job, and making an initial contact with that young person on the phone or by text, and actually being, congratulations, you're having a baby. And they may have been the first person to say, congratulations, because that may be the expectation of other people has not been that. So it's about that literally that introductory contact, that we are quite assertive and sensitive to that young person, but we are quite assertive in our engagement. So we are quite tenacious as a team, particularly my nurses in the team. We don't give up, and we will try, and there's a real fine line, and supervision is really important in this, about not feeling that we are hounding a young person because they may have had experience of being groomed and by other people. So it's about sensitive but assertive engagement to help them understand what it is that we can offer as a service, and that we make an effort to do that, but that we also respect that that may be difficult and that we need to allow them time. And that takes us back to that importance of trying to engage them early in their pregnancy, before long time before the baby's here, so that gives us the flexibility to build that relationship. And that can take weeks, and sometimes that can take months to even get to a meaningful position of engagement to be able to do the work. But it's about going back, sticking to our appointments, trying not to let them down, and setting expectations and boundaries. And we're very clear about our offer. So thinking about an adolescent who may find it very difficult to plan or is not used to having a structured day or appointments, our expectation is we're trying to sort of model some of that behaviour, to put some of those boundaries. So the expectation is that we will see you regularly, that we can be flexible, but to get the best out of a programme that offer, we need to there's a commitment on both sides. And as I say, that can take some time and some really sensitive thinking about how best to do that, because of really looking at where that young person's coming from. Next slide. So we talk in FMP about agenda matching. We're looking at very much about where that young person is, about accounting for their individual circumstances and walking alongside them, and rather than doing to them. So we really try and be alongside in terms of what their aims are, and to work with that rather than against it. Through the pandemic, we've obviously had very different had to have very different ways of working, particularly in the early weeks, sort of this time last year. And we've had quite surprising responses from our young people about the use of video calls. We have always been a face-to-face service. Some young people really have not liked video calls. They don't like to be seen. They may not have access to Wi-Fi to be able to support it. And others found it's been a really good way to start to build a relationship, to get to know somebody, to trust them, to develop that trust through this a less invasive personal space online, to be able to do that. But it really is very, very individual. Next slide. Oh, I think that's it. So I hope that's given you a little bit of an overview of what we do as a service, but also how we work or try to work, particularly with children in care, but also with any vulnerable young person who is referred into our service. We have a central contact number and telephone, and anybody can notify us of a young person that they may be working with, and we will take their details and look at whether we're able to offer them a place. I'm really happy to answer any questions that people have.
Thank you so much, Fiona. Do you mind if answering questions via the chat box?
That's fine, yeah.
Because then I've got a last little bit to do about resources and some training that's coming up, and then that'll fit in and everyone will get away at 11:30. So if you're all right with that, but thank you so much. I really love that, and a lovely reminder of the adolescent brain and all of the other stuff that's going on at this time. So yeah, thank you so much, and it's fitted in brilliantly with today's theme about care leavers. So thank you. So yes, if people want to ask Fiona questions in the chat box, and then I'll just do a little finishing off bit with about resources. And a couple of bits that are coming up. Okay, so next slide, please, Sian. There's a couple of awareness weeks coming up that are very pertinent to perinatal. So I just wanted to make you aware. The first one is Maternal Mental Health Week, and you can see there from the 3rd to the 9th of May. So there's a different theme every day, and you can follow that on social media, and there's links on the slide. Okay, next slide, please. Of quite particular importance with the webinar, with the Maternal Mental Health Week, is that the middle of the week is World Maternal Mental Health Day, but this doesn't yet have recognition from the UN. So I would just urge you, when the slides come out, that link at the bottom goes to a petition that you can sign to try and get UN recognition for World Mental Health Day, World Maternal Mental Health Day, which I'm sure you'll all agree would be a fabulous thing to happen to raise the agenda. Okay, next slide, please. And then following on in June is Infant Mental Health Week. So that's from the 7th to the 13th. And I'm sure that there'll be a lot more comms coming out about that a bit nearer the time. I also wanted to highlight you. This is one I've come a bit late to because it has been around for a little while, but the Duke and Duchess of Sussex have done a lot of work with the BBC for this Tiny Happy People. And I came across it the other day, and there's some lovely resources on there about play and particularly language development, if you're interested in signposting some of the people you work with to those. Okay, next slide, please. This is particularly with our maternal mental health services scoping work and our early implementers in mind and our fast followers, that I found a leaflet on primary tocophobia that has been co-produced by women with lived experience. So I think that link takes you to the leaflet, and it might just be a good one to include in your resources. Next one, please. This is just a heads up on a couple of our training courses that still have just a few places left, and obviously we're keen to fill them. So this is training in June, both from the Institute of Health Visitors, and one is Dads and Partners training, and the other one is the Perinatal and Infant Mental Health Champion training, both of which we've had fantastic feedback for. So if there are any more people out there who want to put staff forward for this, do get in touch, and the details are on that slide. Next one, please. Okay, so we're just about there now, and we're just about in time. So I really want to highlight, oh, and in fact Liz is going to do this bit, I'd forgotten that, so sorry.
I'll let you have a final comment. And
I was just going to say, I really want to highlight this one in May as well, particularly in the light of the maternal mental health services. So please spread the word. We're having a whole webinar on women who have babies removed, and just to remind you all that that is an ask of the maternal mental health services, that we really think about what these women need within that. So I'd really highlight the one in May for people that are involved with those services, as well as anyone else that's interested, because I know that affects most of us across the perinatal pathway at some point or other. So that's what I was going to say, Liz. I don't know.
So I was just going to follow up on that and say thank you to our fantastic speakers today, as always. Lots of thought-provoking information given there that we will revisit in later sessions. Can we just have the last slide, Sian? Lovely. So just to remind you that the recordings for all the webinars since January are on a different page. The link is on the original page, but the details are there. I know a couple of people were asking in the chat box about slides. Slides will be sent out following the webinar. They normally go out by the end of the week, if not Monday next week. And if you are not currently getting invitations, if you can email England, the email address there, we will make sure you get added to the distribution list. Thank you all very much, and we wish you a good rest of the day. Bye-bye.
Hi, thank you again, Fiona. I think you're the only presenter left on the call, so thank you very much indeed. That was amazing.
Thank you.